not think I was going to be a doctor. I was not pre-med in college. I was a neuroscience major. I never considered medicine at your age, which is kind of interesting, I guess. It was a very organic change. My father was an emergency room physician in the south side of Chicago. So he worked a lot of night shifts, and I was really close with my dad. And I would spend nights at the ER watching him interact with patients.
Wait, I didn't remember what I was saying. Oh yeah, I'm
and take care of people and kind of that type of thing. And, I loved what he did, and I really admired him. I thought the way he treated patients was amazing. But I didn't think I was going to be a doctor. So I went to college. Again, I was really fascinated by how people make decisions, how the brain works. I found that fascinating. And I went abroad my junior year in college, and I did a trip called, which I recommend anyone of you in college. It's a broad trip. It's called Semester at Sea. And you sail around the world. You do a full circumferential path around the globe in a boat with other people, and you stop at different sites around the world, and you get off and you spend a week or 10 days at a site, and then you get back on the boat, and then you go to your next port of call. That's called Semester at Sea. And while I was there, I spent some time in South Africa. And so after I graduated from college, I moved to South Africa, and I lived there for 2 years. And I was teaching English for a year. And then I worked with some South African NGOs called Sports Coaches Outreach. And we brought sports coaches into the townships of South Africa and taught sport as a way to improve confidence and community and health. And it was there when I was in South Africa. So I was, I spent my 21st birthday living in South Africa. I graduated a little bit early from college. So when I was 21, that's when I decided to become a doctor. So I had taken no pre-med classes in college. I had already graduated. And it was at 21, I said, I think I need to, go to medical school. And I thought I was going to do like Doctors Without Borders or something. So I came back to Colorado. That's where I'm kind of from. And I did all my pre-med classes in a year and a half. I did all of them together. And at the same time, I was working in a lab doing some nutritional research. Specifically, then I did some research in Guatemala and Peru looking at zinc deficiencies in children. Diarrheal illnesses are the #1 cause of death worldwide for kids. And we were looking at how to improve the diets of people in indigenous populations in Guatemala and Peru to improve their longevity. So I was kind of on this, international health, Doctors Without Borders path when I started med school. So I was a little bit of a late starter. So I didn't go to med school until, what was I, 26, which is late. Okay, that's late for a lot of people, but and this is one thing I was like really shocked to hear you guys are all in high school because, okay, couple of things I want you to think about. You have plenty of time. I think the best doctors are really well-rounded and have a lot of life experience. So if you don't go straight through, high school, college, med school, that's totally fine because you'll probably be a far better doctor if you can have some life experiences before you become that healthcare worker. And the reason why is that, you learn things in books, but as a physician, the most important thing is connecting with the patient and having them really feel like they're a team with you and working with you to help them with their diagnosis. So, there's being a really successful doctor, is not just about acing all your tests and memorizing these ridiculous number of things that you have to memorize. The really thing I think that makes doctors special is the humanity of medicine and really connecting with those patients on that level and communicating so that they understand why they're ill, so they understand what's going on in their health, and then being able to help them through that journey. So I was very atypical. So I went to med school late, and then unfortunately, if you remember my dad, so he was the ER doctor, and we were very close, and we used to exercise a lot. I ran track in high school and college. I really, really think exercise is the best medicine out there. And he was visiting me as I think I was like, yeah, first year med student. Yeah, as a first year medical student. He came up to Colorado, so we were at altitude, and we went for a run. And after he was going to go back to San Francisco, where he was living, he said to me, or pardon me, back to Chicago. He hadn't moved to San Francisco yet. He complained of some shortness of breath. And he just said, you know, I think this altitude's really bothering me this trip. That's so strange. Well, you know, being a doctor, and doctors can be really the worst patients that there can be. I must tell you, doctors are terrible patients, as are nurses. He went back to his ER in Chicago, and he got a chest x-ray, and he had a very enlarged heart, and it's called a cardiomyopathy, and he was in heart failure. And he was subsequently diagnosed with heart failure and passed away of sudden cardiac death at 59 when I was a third-year medical student. So his death, as a otherwise very healthy person who had inherited, it turns out we have a family history of cardiomyopathy. So he didn't have any heart attacks. He didn't have, you know, blockages in his coronary arteries. His cardiomyopathy is a familial cardiomyopathy. So it's something within the genes of our family, and that kicked off the heart failure. So that obviously had a huge impact in my decision to go into cardiology. I remember I was actually studying, as a third-year med student, studying the pathophysiology of the cardiovascular system when my dad was admitted to the hospital after he had a stroke, which was associated with his heart failure. And so that, of course, had a huge impact. And I think it also really helped me to understand what it felt like to be on the other side, to be part of the patient's experience. And what does it mean to when the doctor comes in and talks to you and tries to explain anything. And even though I was in medical school, you know, you're an idiot in medical school. You really don't know anything about medicine even after you graduate. There's so much experience that you get. So that was very profound, and I grieved horribly. It was very difficult for me. I probably did not take enough time during med school. I didn't actually take any time off. I just kind of barreled through, but that was how I decided to go into cardiology. When you go through medical school, you go, all the rotations are so much fun. And they teach med school differently now than when I went through. There's a much more hands-on approach. There's a much more better clinical approach. But when you graduate from medical school, you know, you kind of have tried out different rotations. And typically in some of your rotations, something starts to speak to you. Something starts to feel like the right path. Something just feels like you belong there and that you don't ever want to leave the hospital when you're on that rotation. And I really believe that doctors still have a calling. I don't think this is a specialty or a profession that is for everyone, because there's so much work with it that you really need to love it. So that's kind of how I got into cardiology. I still, you know, I must say, you have plenty of time. I do recommend also, in regards to applying for medical school, having a really unique life experience. That is so important. That makes you such a better physician, to understand what it means to have a job, take care of a family, travel, see how other cultures live. Because those of us who, you know, if you're just studying all the time, you're in the middle of your books, you lose out on really what the real world is. And you're going to need that resilience and those life experiences in order to get through medical school, to get through residency, because it's such a long haul. So I did a lot of travel after college. Obviously, I lived in Africa. I lived briefly in Guatemala and Peru doing some nutritional research, traveled all over Europe, really got out there and saw a lot, developed, you know, a real strong, I feel, moral aptitude for my beliefs. And those experiences just made me a very grounded medical student, and I think a very good understanding of humanity. Because, yeah, the best doctors, I think, are those doctors that can connect with their patient. Because if you can't connect with your patient, they're not going to do anything you say. You can you can prescribe all the medications, you can give them the best advice out there, but if you aren't connecting with them and if they don't feel that you're listening to them, it kind of all goes down the drain and you're wasting a whole lot of time. That's my philosophy. I think it's worked well for me. I've been a cardiologist now for 10 years, 11 years, and I love it. And I would never do any other specialty. I loved all of my rotations in medicine, but the minute I delivered a baby when I was a third-year medical student, I was like, gross, this is like the miracle of life, but I don't want to go into a specialty that you need galoshes for. There was too many fluids. I mean, it was really amazing. Everything's really cool, but you definitely learn kind of what works for you, what speaks to you. And there is a really big thing to think about of knowing yourself. And that's the other thing about having some life experiences before you go to med school. If you don't do well with sleep deprivation, don't go into cardiology or critical care, because or OB, you're going to be woken up at 3 o'clock in the morning to deal with an acute heart attack. So you learn that thing through training. Although now with training and med students, they give you guys a lot more naps these days. It's really funny. We were up, 36, 52 hours straight and had to function, and that there's some safety concerns there, but you definitely realize, hey, I'm good on, no sleep. I can get up out of bed from a dead sleep and run to the ER, or I can't. So having a lot of self-knowledge about how you function, how you feel, that's another really important component of how you choose your specialty. But I loved all the specialties, but I don't think I would be any other doctor other than a cardiologist. I don't know. I can't see myself doing anything else. So after you graduate from med school, then you choose your kind of path, right? So you either do internal medicine if you want to subspecialize into the different medical specialties, or you go anesthesia or the surgical specialties. And you don't have to choose a medical subspecialty until your second or third year. And that's where you say, yeah, I want to do GI, or I want to do pulmonary, or I want to do cardiology. I did a chief year, which was also great. So I did so you do 3 years of internal medicine training, and then if you're a chief resident, you kind of run all the other residents and work as kind of an attending, which was a great experience as well. And then you start fellowship, but medicine is truly an apprenticeship. So we do joke that, every July when all the new doctors are starting, everyone's a little nervous because these are brand new doctors. So we watch them really closely. And for example, our fellows just started in July, and they've been doctors now for 3 or 4 years, but they still know nothing. So we watch them really closely. And we really, it's a real big apprenticeship. So the other thing I would recommend is, and this is something I wish I had done when I was in med school, find mentors. Find a professor or a doctor that you really admire, that you really think is a good person, that you really think is doing the right thing in regards to their life and medicine, and learn from them. Because you need a lot of help to get through medical school and residency. And the more help you can get, the better. So, you know, when you get into medical school, you know, you're really with definitely probably the top 10% of people that, you know, were in your college and in school, and everyone has unique gifts. But being a really good doctor, again, it's not just the memorizing the facts, but it's learning how to run your life effectively so that you can take care of your life, you know, and your patients, and still be happy and still be healthy and still learn. So so that's kind of my story. So that's kind of how it was a very organic it was a very organic kind of development for me to become a cardiologist. And I did fellowship here in La Jolla at the Scripps Clinic. And after I finished fellowship, I was, they asked me to stay on. So I've been here at Scripps since the 2000s. And I've never had another job other than here at Scripps. And the reason why I stayed where I trained was because of my colleagues. So I work with just an amazing group of people, and you'll find that, you know, your medical school friends or your residency friends become lifelong friends because you really are like in this incredibly intense, you know, environment. So I think the takeaway is, especially for you guys, don't feel rushed. It's really good to get some life experiences. You don't necessarily have to go straight into med school. Really focus on knowing yourself, your strengths, your weaknesses, where you do the best in regards to, you know, I'm really good at handling stressful situations versus I'm incredibly meticulous and detail oriented. Maybe you need to do more of a research path. So take that time to really understand your strengths and weaknesses. But in all of it, find a mentor, have multiple mentors, seek help, and know yourself. I think that's the most important thing, because I think when you're young and you're going through all the tests and you're writing all these personal statements and you're applying and you're applying and you're doing all these things, you feel like it's always just one thing after another. And I will say that even though I started late, you know, now that I've been practicing for over 10 years, I've got, you know, decades of more practicing cardiology to do. So you'd never feel like it's too late to do anything. So I think those would be my big top 4 things of advice and insights I have for you guys. So that, I think that's about 20 minutes of me talking. Do you guys want to open it up for questions?
Yes. A few of the actual talk was very interesting. Thank you for giving it to us, and thank you for joining us today. We gave a survey to all our students to provide us with a few questions.
Oh,
and
yeah.
The first question is, what is the most challenging aspect of being a cardiologist?
Oh, that's a good one. I was thinking about that. So I think the most challenging thing for me is the darn paperwork. To be honest with you guys, I hate paperwork, and you do it a lot as a doctor, and lots of forms to fill out. You know, you have to be really meticulous in writing your notes, and that's the most challenging in regards to the negatives. Okay, we like cardiology because it's challenging in regards to thinking about what's going on with this heart. Why is this person short of breath? What's this arrhythmia mean? But those challenges are fun, because cardiology is a disease where you're always seeing new ramifications of a different disease type. You're always learning. You're learning from each patient. So the clinical challenges are wonderful. In my work, I cover the hospital every month, about a week, So I'm doing inpatient cardiology and clinic cardiology. And clinic cardiology, you know, you're just seeing patients in the outpatient setting. Again, lots of paperwork. So I think that's the biggest negative, is the paperwork. That's the worst part. I'm not good at it. And I don't think I'm ever going to be good at it. And I'm okay with that. You know, so just kind of struggle through it. But the better challenges are, oh gosh, this is a good one. This goes back to what I said before. So the clinical challenges, these are fun. So, you know, when you're rounding in the morning and you're seeing a patient and you're trying to figure out what's causing the chest pain, what's causing the shortness of breath, what's the arrhythmia all about, how does this valve relate to this valve, those challenges are wonderful. And so that question is great, but the clinical challenges, those are fun. And that's actually why we get into it. So we're never bored. Again, the worst challenges are the TDM, dealing with insurance companies, getting medications covered for my patients on their insurance, getting a test covered, doing that administrative stuff. That stuff is not fun. Those are the tough challenges. And I think every specialty has those. Those are always kind of a downside to medicine. We are a very inefficient system. So if you look at engineering or software development or, you know, even, I think even university administration, medicine is really behind the time in regards to making our work days efficient. So, you know, I saw about 17 patients in clinic today, and I've got probably another 2 more hours of paperwork to do and checking tasks and redoing, you know, refilling prescriptions and looking at lab values. So, you know, I put on some good music and, you know, sit in my office, which you can see behind me, and, you know, kind of just burn through it. But that's kind of that's probably the most challenging aspect of medicine. The other challenges, again, the actual clinical stuff, those are so much fun that those are great. We love those. Those are really great.
So our next question is going to be, what's a mistake that you made early on in your career, and what did you learn from it?
Okay, so I think the biggest mistake I made was what I alluded to earlier. I think I didn't ask for enough help. So when I started med school, and I didn't really understand the path from medical school to residency to specialty. And I also was a little bit out of practice with studying, because I had graduated from college at 20, and it was 6 years before I had started studying again. So, and I just thought, oh, I can do it. You know, I can bang through these tests. And I remember something that my roommate in medical school, she was a year ahead of me, that she told me, and I wish I had listened a little bit closely to her. She said, don't resist the work. And I'm a natural crammer. I cram for tests. I don't recommend it, but that's just who I am. And there's so much abundance of work to do that, again, if you know yourself and you say, you know what, I'm not a good test taker, or I'm not good at rote memorization, ask for help. I think that was the one thing, because then I found myself kind of panicking, and I had to kind of rethink about how to learn in medical school, because it was very different. Because in my undergrad, I was in labs and writing essays and doing research, and that was very easy for me. Medical school, it's a very different type of learning. So I think that would be one instance. In work, work's been, I don't think I made big mistakes in medicine and internal medicine, my residency or my fellowship. I think one thing that I would share with you guys is, when you're in medical school and internal medicine, if you're doing your residency, whether it's internal medicine or surgery, when you decide on a specialty, during those acute years, and this goes to one of your guys' questions about life balance. You really need to let your family members know that, you know, school and training is going to have to come first for these next couple of years. Because, and that's okay. It's okay, I think, to be a little selfish during that time, and know that you need to really focus on building your career at that time and learning the basics about what it means to be a doctor, because you're choosing your specialty, and you really want to make sure that you're getting your exercise, taking care of yourself, getting enough sleep. And I will say that family who has not gone through medical school or residency can have a very difficult time understanding that. And they might say, you know, you're being selfish, you're never home, we never see you. That's a real tough one. And I think one thing I learned is I learned to never promise what time I would be home, because if I said I'll be home at 7, I wouldn't get home until 9 o'clock. It just seems to work out that way. So don't ever promise you're going to be home at a certain time, because you're probably going to disappoint someone. So you'll have some emergency that comes in and you have to delay coming home. So, you know, I think you have to realize that in the beginning of training, you really want to say, you know, of my whole pie of life, that training's taking up, you know, 75%, and you've got to give it the respect that it needs. And then once you become established, like now, you know, I've got much more work-life balance, but you have to understand, and you have to try to communicate with family members that during your training, you know, you're not going to be around as much. And that's very hard I think, for some family members to understand. I think that one is tough, because yeah, there's a lot of guilt about, you know, missing maybe holidays, being on call, or being really sleep deprived, and you can't necessarily be there for everyone else in your family that you need to be there for. You know, again, when my father died during medical school, I didn't take any time off. That might have been a mistake, because I was so, you know, I think I was just in so much grief that I did my neurology rotation right after my father died. And to this day, I don't remember the whole rotation at all. So, I mean, I would think I was just so full of grief that was a really difficult time for me. And I think it probably would have been better to just, you know, like I said before, ask for help, take some more time. But it's a very weird life to be going through medical school and training. One of your guys' question was, how many hours do you work? You know, when you're training, you're working 80 to 100 hours a week during your training. And now, you know, as an attending, I set a lot more of my own hours. So if I want to take a week off here or there, I can. I take off half-day Fridays. I have much better balance now. But to get to that position, I had to really dedicate my time, you know, and let my family members know, hey, I'm not gonna be here. I'm gonna miss that holiday. I'm gonna miss this family trip. You know, that was a big challenge, and that was probably, I think, where a lot of people can. That's where a lot of people can get a little bit down in the specialty and get a little bit more burnt out, because you have to just kind of grind through those years of med school and training.
Thank you for that. Another question another student had was, how do you handle the stress you experience in your job and balance your life outside of work?
I run. So that's a huge thing. I don't believe in the idea of work-life balance. I think that's a wonderful little phrase. I think one thing is this, I insist on exercising every day. Absolutely. I eat very healthy. I'm one of those doctors who practices what I preach. So I'm very strict about nutrition. I'm very strict about exercising regularly. I love sleep, so I make sure I give myself a lot of sleep. Well, okay, so you get sleep deprived in med school, but then, you know, you find time to catch up and get naps. But I also, you know, after I got through training, I made sure that I started doing things outside of medicine that I love, which is, for me, I ride horses. I love horseback riding. My husband's a horseback rider as well. So, you know, you have to make sure that you, again, always know what's important to you. The specialty of cardiology feeds me, meaning I love taking care of my patients. I love what I talk about all day long. That's really important, because when you're a doctor, again, if you want to be a really successful and happy physician, you have to believe in what you're doing. And you have to believe that what you talk about all day long to your patients is something you truly believe in. And so one of the beautiful things is that my life kind of mirrors everything I tell my patients all day. I tell my patients all day long, exercise every day, get restorative sleep, obviously never smoke, eat well. This is what I eat, you know. And so the profession of medicine is so inherently humanity. Again, going back to the idea that, you know, the best doctors are humanists, really understanding the human condition. If you really love what you do and you really believe in it, then that gets reflected in your care of your patients, and that feeds your life. Now, that being said, like I said before, I only work 4.5 days per week. I know if I try to work too much, I get really burnt out. I love doing inpatient medicine and outpatient medicine, so I've been able to create the job that helps me. For a while, my husband was living overseas, and so I would take 1 to 2 weeks off every month and travel down to see him, and that was a wonderful break. So one is, I feel like I love my job and I love my patients, and so that makes me really happy to go to work, despite all the terrible paperwork and all that other stuff I mentioned. But two, I think my profession is so in line with my own belief of health that it makes it really on par, and it actually makes my life very harmonious. So everything, again, that I do outside of cardiology reinforces what I tell my patients all day. And I think that makes for a very balanced and harmonious kind of life. I feel like I'm very, very honest with myself and with my patients. I think if I didn't like my job, I would just quit. And I think a lot of physicians have, and you guys have probably heard about physician burnout. Physicians who feel like they aren't appreciated, or a lot of physicians tell their children not to go into medicine. And I think part of that is that there's that disconnect with saying, you know, who am I as a physician? Does that line up with who I am as a human being? So for me, the balance is, again, taking really, really good care of myself. Again, insisting on exercise. I'm a morning exerciser. I run in the morning. Even through the pandemic, fortunately, I've been able to run on the weekends. I ride my horses. I love my dogs. You know, I love reading. I'm working on a book. So I make sure that I always come back and give back to myself. And some people would say that that's selfish, but I would say that actually makes me a better physician for my patients. So the balance, again, is knowing who you are, knowing really what drives you, what feeds you, because even though a lot of people like to say that you shouldn't be defined by your job, I think as a doctor you are. I think because your patients are going to look at you and they're going to say, well, would I want to live like my doctor is? Would I take my doctor's advice? And if they see that, like, wow, this doctor looks burnt out and tired and you know, doesn't exercise or doesn't, you know, I'm not going to listen to that doctor, right? Now, obviously that's very important in regards to cardiology, right? Because we do a lot of lifestyle change. So again, I think being a physician, because it's so time consuming and it's such a huge commitment, I really think that you need to be, you have to really make sure that your belief system and how you're living your life is in line with the type of physician you are. So I think that, I hope that makes sense, but that I think overall helps with your balance of life. Because yeah, doctors, you know, you guys, you know, the work never stops. You know, you can work from home, you can be checking labs at any time of the day. Some of my patients have my cell phone number. The nurses sometimes will call me, and I'm not on call, I'm not covering the hospital, but I'm there for them. And I love that about being a doctor, but yeah, that can, if you don't take care of yourself, that can become that's why I think a lot of doctors suffer from burnout. So you have to kind of know, hey, I need to take a break. I need to get out of the office. I need to go hang out with my dogs. I need to go scuba diving, whatever it is that really, you know, again, knowing yourself, knowing what really makes you happy, and that will make you actually a better physician.
Yeah. So our next question is going to be about what was the most difficult / rare case that you've ever encountered, and how have you handled it?
Oh, that's a good one. Let's see. Well, recently, let's see, I've got one that was, this is actually kind of personal too. So we had a family friend who happened to be one of the vets for our horses. So he was an equine veterinarian. And this guy, he was in his late 50s, and he had undergone radiation therapy for lymphoma. So he had a large mass in his chest when he was in his 20s. So you can imagine that was about 30 years ago, and he had a lot of radiation to his chest at that time. The lymphoma was treated, but one of the unfortunate side effects of radiation treatment, specifically if it's going to the chest, and we see this with women with left-sided breast cancer, is it can affect the heart. So here he was at 57, and he was in heart failure. So because of the radiation, and he also had what we call obstructive coronary disease, he had blockages in his coronary arteries to the heart, he was in heart failure. And all this time, though, he's still working as an equine veterinarian. So he's dealing with horses who, you know, weigh 1,500 pounds. And he was this incredibly smart guy, but he was really getting short of breath. And he had been followed by another cardiologist. I wasn't his personal cardiologist, but I was just kind of giving him some advice as a friend. And I had said, Steve, you know, I don't think you're on the right medications. I think you need to be in cardiac rehab. I think we should, you know, can we just get an echo? I'm curious to see what your heart looks like. And he did this, but because of insurance reasons, which was really frustrating, his insurance wouldn't cover some of these tests. So he wasn't getting the most optimal cardiac care for a couple of years for his heart. And then one night I was actually on call on the weekend in the hospital, and they called that's called a STEMI call, meaning there was an acute heart attack. And they had already wheeled him into the cath lab, and I came down to the cath lab, and there was my friend Steve, and he was having a massive heart attack. And, you know, luckily we fixed the coronary arteries, we opened up his coronaries, but, you know, now he was in the hospital. So when you get admitted to the hospital, insurance changes a little bit. So we were able to get all these tests. Well, lo and behold, unfortunately, his heart failure had gotten much, much worse, to the point where something we call the ejection fraction, his heart was barely pumping, and he needed medications to help support his blood pressure. His blood pressure was so low, his heart was so weak, it could not generate a normal blood pressure. So he's in the ICU, and you know, this is where I was having to teach him what's happened to his heart. He was in extreme heart failure, but we couldn't blame the blockages that he had just been treated for the heart attack on the heart function. And I really began to think that we were seeing a 20-year effect of that radiation for his lymphoma show up as heart failure. So it's a late development of heart failure in people, in young people who got radiation therapy to his heart. So unfortunately, he needed a transplant, and he was initially very resistant to that. There are only 2,500 heart transplants per year in the United States. So, and that's been a pretty constant number for the last 20 years. And it's a really, you can imagine, it's a huge surgery, and you pretty much become immunocompromised the rest of your life. Heart transplants are one of the toughest organs to get through in regards to those surgeries. And he really didn't want to go through with that. Here he was, a veterinarian, and he thought that really didn't kind of jive with his lifestyle, which he's right. We have some other things we can do for people with heart failure. For example, left ventricular assist devices, where they have a pump inside their heart and they wear an external battery pack, and they're constantly changing out their batteries. But that pump is keeping their heart alive. It's considered a bridge to transplant. But those people have a lot of bleeding problems and infection problems. And again, you can imagine, being an equine vet, he was already at risk for infections being around horses and animals and farm settings. So he was kind of resistant. So Steve kind of plundered along. He got out of the hospital. We got him on the right medications. And after, months of really counseling with him and talking with him, I convinced him to get a heart transplant. Now, we don't do transplants at Scripps where I am, but we sent him to UCSD, which is right next door. I can see their building. Hi, guys. So we send our transplants to UCSD, sometimes up to Cedars in LA. And he was finally on board. And here was this, again, he was only 57, so excited, and finally agreed to undergo this surgery, understood his diagnosis. And they got a CAT scan of his chest, because before you get a transplant, obviously a lot of testing goes through. You're on the list for a long period of time. And they got a CAT scan, and I actually was not in San Diego when this happened. I was overseas with my husband, and one of the fellows from UCSD called me, and he said, Dr. Adams, I have some bad news. He says, Steve has cancer, and his cancer had come back, and you can't get a heart transplant if you have active cancer. And that took him off the list immediately. And unfortunately, he died about 6 weeks later. And that was probably the most heartbreaking things, because he was such a man full of life. And, it took so long for me to convince him to get the right therapy and, get on board with the transplant. And when he finally did, something else was there. Now, the cancer, again, didn't kill him, but you have to be cancer-free for a certain amount of time before you can get a transplant, because if you get a transplant, you become immunocompromised. So most likely he wouldn't have been able to undergo the surgery. So that was pretty heartbreaking, and that was pretty difficult. That was probably the most challenging case I've had recently, just because it was so heartbreaking. Here was someone who had so much love of life and was doing such amazing things in his life, and we couldn't help him. So that was probably the most challenging thing I've been doing lately. That was definitely the hardest thing.
Thank you for sharing us that heartbreaking story. The next question is, what are some stereotypes about cardiologists that are not factual?
I don't know. What do you guys think are what are stereotypes of cardiologists that you've heard of? Anybody have any ideas?
Yeah.
You're going to mute yourselves accordingly to ask.
Or say it
Oh, well, a stereotype that I've heard is a lot of people think that cardiologists are like health nuts. They love health, and they're always like worried about exercise and about their health and, BMIs and all that stuff. So would you say that's true? Or?
I would hope that's true. To be honest with you, my dear, the reality is that most doctors are not healthy. I would say never trust a fat cardiologist. You know, I think, again, in cardiology, we do, okay, well, here's something you guys should know. So yeah, so that might be, I wish that stereotype was true, but to be honest, a lot of my colleagues don't exercise regularly, don't eat well. But I do think, again, cardiology is one of those specialties where you should practice what you preach. I used to, when I was in medical school, they would say WWAE, which is what would Adams eat? Because I would be like, no pizza and no donuts and no Coke, you know, because because most things for heart disease, you guys, 80% of heart disease in America is preventable with lifestyle. But unfortunately, you know, with the doctor's lifestyle, again, you're sleep deprived, you don't necessarily, you can't eat regularly, you don't have time to exercise. I think that's a big problem in medicine. And I think that in medical school also, you guys are only going to get about 3 hours total of nutritional training. So most doctors don't know anything about nutrition to begin with. And remember, in Western medicine, specifically in United States medical schools, you guys are taught how to treat disease. You don't really treat how to prevent disease, and heart disease is mainly preventable. I mean, in my father's disease, for example, you know, that was genetic. So, you know, so that is kind of one of those things where you can't, unfortunately, get away from. You just have to monitor yourself and treat yourself, you know, and kind of screen yourself early. But the vast majority of heart disease in America is preventable. And the American lifestyle and what we eat and our sedentary behavior and our rising waist circumferences and our lack of activity is definitely a problem. So again, I do believe that cardiologists should practice what they preach, but I have to say that I don't think all cardiologists do that. I have colleagues who, you know, won't see patients until they have that heart attack. I do a lot of prevention, so I like to do a lot of primary prevention, but then obviously I meet a lot of people after their heart attack, and I have to say a lot of my patients are healthier after their cardiac event because they finally have that wake-up call of, yeah, I got to start paying attention and really taking care of my body. So unfortunately, I don't think that stereotype is true, but I wish it was more true. I would say that, my dear. So have you guys heard of any other stereotypes on cardiologists that I can comment on? I do think one of the things is cardiologists are very type A. That's true, meaning you definitely want to be able to be confident in a stressful situation and take over running a code, for example, or really feel comfortable when someone is not doing well, either a dangerous arrhythmia or not able to breathe, of making quick decisions and, you know, rushing to the case, loving being in the ICU setting. That's very important for cardiologists if you're going to do inpatient medicine, because you're going to be called to all the emergencies in the hospital. So you don't want to be timid. You really want to be kind of aggressive and saying, okay, I'll figure out what's going on and I'll act on it. That's a very true stereotype. That being said, it's not that when you get to the code or you get to a situation, being cool under pressure, I think that's a stereotype that works very well in cardiology. So you want to be able to have a lot of resilience and be able to make quick decisions, but remaining calm, because that's really good for everybody in that setting and definitely good for patients as well.
At this time, we want to, after giving us all this story, if anyone has any questions, we're opening the floor up for anybody who has any questions. You can unmute yourself, or you can put it in the chat window to ask Dr. Adams.
I wanted to ask you, Dr. Adams. So,
Yeah.
How does a typical day for you go in the hospital when patients visits? Like, what do you do on a typical day, and how do you help others, specifically like in the face-to-face?
Yeah, that's a great question. So let's talk about when I'm in the hospital.
Mhm.
Typically, we have a cardiology fellowship program. So usually when we do rounds, which is when we go see all the patients, the cardiology fellows and the residents and the medical students see the patients first. And then we go to rooms. We happen to have or the emergency room, and we see the sickest patients first. So we start usually around 8 o'clock in the morning. But so as you guys know, I insist on going for my run in the morning. So typically what I'll do is I'll get a phone call at 7 a.m. And I get kind of a little rundown from the fellow who was on the night before. I hear about the new patients. If they're worried about any lab findings or any EKGs, we kind of come up with a plan right then and there. And then I go for my usual run, and then I meet them at the hospital, and then we start doing what we call rounds. So we start at the sickest patients, typically in the ICU, and then we come up with our plan. And during COVID, and I'll definitely answer that COVID question. Unfortunately, family members can't be in the hospital right now with their patients. So we have to call family members afterwards, but we examine the patients, go through the labs, talk to the patients, interview them, do their physical exam, communicate with the patient as to what our plan is. The nurses are typically rounding with us. We'll also have a pharmacist with us as well. And we just kind of go, patient by patient. We try to finish with rounds. Rounds will take like 3 or 4 hours. So we'll have between, 20 to 30 patients who are really sick in the hospital. We see all them. And as this is going on, we maybe run down to the ER to help somebody with an arrhythmia, or go to the cath lab to see if there's an acute heart attack. So it kind of just depends on what emergencies come up. And then at noon, we let the fellows go to their lectures. So the fellows have to get lectures on different topics. And then I typically go back to the hospital, see patients, check up on things, do a lot more teaching with the patients. We're on our feet all day long, and I make the fellows all take the stairs. So they're getting a lot of steps in every day. So usually we usually walk, I think the last time I was on the inpatient service, I think I clocked in 80 flights of stairs one day, which was great. And, we just kind of do case by case. So sometimes, usually we have to go back in and follow up on some tests, but it's always about, hour by hour, things can change in the hospital, specifically on our really sick patients. So we kind of do the most critical things first and then move on. When I'm in clinic, I typically, again, I run in the morning, then I go to work. I do another program called Executive Health, where I meet with healthy executives who are kind of doing treadmill tests, and we do a lot of prevention with them. I meet with them, do a lot of teaching on heart healthy stuff, and then I come over to clinic and I see 20 patients. I work through lunch, then do like 2 hours of paperwork. On the weekends, if I'm on call, again, we start the day usually similarly. We're walking around the hospital, seeing everybody, and discharging people, and then seeing more patients as they come into the ER. So we're all over the hospital. On certain days, I do procedures in the afternoon. So I have certain days where I'm down in the cath lab, or I'm doing other procedures like cardioversions or transesophageal echocardiograms. So for example, tomorrow from 1 o'clock on, I'll be doing procedures all afternoon. So that's really fun. So it's a lot of variety. It changes things up. But the nice thing about, for example, our hospital, this sounds like a small little kind of thing, but we have these beautiful private rooms, and there's a huge couch and huge windows and big screen TVs. So when we go into a patient's room, we'll typically spend, 35 minutes to an hour reviewing their diagnosis. We put up their angiogram on the big screen TV, or we put up their echo, and we show them their heart and how it functions. And we try to do a lot of teaching. So the inpatient hospital time is really fun, because you really get to motivate the patient to make those changes, to make sure they understand what's happening, all those things. So that's kind of how the day runs. When you're in training, again, you're working about 80 to 100 hours a week, and you're paid nothing. So you actually, if you do the math, you end up making less than minimum wage. I think I calculated it once. You think you make about $3 an hour when you're in training because you're working so many hours. But as an attending, I do about, 1 week of inpatient hospital per month because I really love it. I do a weekend every couple of months. I'm on call a couple of times at night, but the fellows are doing probably the hardest work of getting paged constantly and having to come in the middle of the night. We only come in the middle of the night when there's a really massive heart attack or someone's in terrible heart failure, or if we have to put in a temporary pacemaker or something. So that's kind of how the day runs. Let me pull up some of these questions. So, okay. So from Nyan, so yes, COVID-19 has really affected my career, not my career, but definitely my work. There have been a lot of cardiac complications associated with COVID, specifically arrhythmias, a lot more clot burden. And in really some of the scariest cases of COVID that most people don't realize this, you guys, when you get a virus, whether it's COVID or influenza, the virus can travel to the heart and cause a massive inflammatory response in the cardiac muscle. That's called myocarditis. So some people have to go on something called ECMO, which is basically your lungs are shut down, your heart is shut down, and we take out all the blood from your body and we oxygenate it outside of the body, and then we bring it back in. Obviously, that's very intense. There's very limited ECMO. Most hospitals don't have it. We happen to have it here. So with COVID here, we did see the cardiac complications. Next, what we saw are people were so afraid to come into the hospital or come in to see their doctor that people were having heart attacks and strokes at home. So we saw a lot of people come in late. And as you probably know, when you have a heart attack, we'd like to deal with the heart attack immediately. We really want our patients to be seen early. We want to take them to the cath lab while the heart attack is happening. We don't want the heart attack to complete because that typically results in heart failure or damage to the heart muscle in the long term. So COVID has had two effects. One, the direct effect of the virus on the heart, which we get called in to see. But two, we're seeing what we call the cardiac surge. So we're seeing a lot of more heart attacks that should have been seen earlier, but people were avoiding the healthcare system. The final thing is with the pandemic, people are not eating as well. They're not exercising as much. They're much more sedentary. And I think the social isolation isn't healthy for a lot of people. So I think people's hearts people are in a little bit worse shape. So I think we're going to continue to see that. Most of my patients have gained weight. Their cholesterol has gone up. Their diabetes is worse. They're not exercising as much. So that has been some of the downsides of the pandemic. Okay, so let's see. Mansi, what motivated me through the most difficult times? Probably the memory of my dad motivated me the most, because remember, he was an emergency room physician. And, on the south side of Chicago, that was pretty intense. I mean, they call it the knife and gun club. And what motivated me again, and I think why I became a doctor and how I practice medicine, is seeing my father, how he interacted with patients as a physician, as an ER physician, was so beautiful. I mean, he was really able to connect with people and make them laugh and give them hope and make them feel comfortable. There was a time, for example, I remember we were in the grocery store. We're like walking down the grocery store aisle, and this woman comes running up to my father. And she says, "Dr. Adams, you sutured my son in the ER, after he was bit by a dog. And you did such a great job that when we took him to the plastic surgeon, the plastic surgeon said, 'You don't need me. These sutures were perfect.'" And she was just so appreciative. And, my father, had such a good bedside manner with people that his memory really got me through, the tough times. But I have to say, you guys, when you're, again, going through the tough times of medical school or being on call, you got to kind of love it a little bit, as painful as it is. And you got to love the people you're going through it. So going through the tough time, one of my best friends now, She works here now, but she was one of my co-fellows in fellowship. And having those people to say, oh my gosh, this is so painful. This is so tiring. I'm so sleep deprived. I'm drinking so much coffee, you know, and being able to kind of have a really good attitude, that's what's going to keep you through it. But ultimately, you know, it's understanding and believing that the work you're doing is so worthwhile and that it's so important to you. And again, that's what's going to make you a really good doctor, is that you really believe in the work you're doing. Because medicine is really tough, you guys. It's really tough. And a lot of times, you know, it can be not rewarding at all. So you got to really love it. And that's always what I go back to. Okay, let's see, what else? Lots of questions. Let's do this quick. In the case of ethics, how would you make the decision between who gets care first if both have the same condition but are a different age? That one is really difficult, you guys, and we've had to actually make those decisions during COVID. For example, when people need the ECMO machine, okay, which is, you know, extracorporeal circulation. We just had this case when I was covering the hospital a couple of weeks ago. A gentleman came in, he was in his 60s. His heart was failing him because of an arrhythmia. Now, the reason why he had an arrhythmia was because he was kind of a chronic alcoholic and he didn't take his medications. So head to head between this guy and someone else who is the same age, you know, if someone has a history of not taking their medications or not following up with their doctors, ethically, we will choose the patient who we think will benefit better from the technology in the long term. We have a case right now in the hospital. This is heartbreaking. He's 42 years old. He's originally from Acapulco. He needs a heart transplant. And he won't get it because he's not a citizen and he has no social support. And I think that that's an ethical dilemma, but to get through a heart transplant, you need social support, you need family members. Now, I don't think that that's necessarily the right answer, but that's the reality. So that's a great question, Trisha, because you know, you will have those conversations. Do you put a defibrillator in someone who does drugs? That's a tough one because the possibility of the defibrillator getting infected is a very real problem, and you might be causing that patient more harm. With this young man we have right now in the ICU, he went into heart failure, unfortunately, because of drugs, cocaine and methamphetamines, but he's been clean for, you know, 4 years. He hasn't done drugs for 4 years. Unfortunately, his heart's still failing, but he will not become a candidate because of the lack of social support, and we don't think he'll survive through the transplant. So those are ethical questions. Typically, when that comes up, and we will have a committee. If we have to make that decision, even if it's in the middle of the night, we have to decide on treating somebody versus somebody else. There's usually a conference call between about 5 of us where we're trying to weigh what's the best decision. And it, you know, it's heartbreaking either way. But yeah, those decisions come up in medicine, unfortunately, quite a bit. Let's see, what is the ultimate reward of being a cardiologist? The ultimate reward is seeing my patients do really well and be healthier after a cardiac event than before, which happens a lot. So I have one patient who I adore. His name is Bob, and he came to me. He actually, unfortunately, had a cancer in his underneath his tongue, and he had terrible controlled high blood pressure. He was a mess. He had sleep apnea. He was overweight. Now he had cancer. So we had to get his heart healthy for all of his radiation, his chemotherapy. So he, because of the radiation, he got to his mouth. He lost all of his taste buds, and he made no saliva. He couldn't swallow. It was terrible. I mean, imagine, right? So he had to get tube feeds. He had to be fed through his stomach with a J tube. And if you ever look at what's in tube feeds, this artificial feeding treatment, it's terrible. It's high fructose corn syrup. It's artificial. It's awful. And he and I found this amazing kind of real food that he could get through his tube feeds. And he started exercising and he got his blood pressure under control. And today, Bob is healthier now than he ever was. And he obviously beat his cancer and he's doing great. So seeing my patients kind of really do well and stay healthy is the most rewarding thing, because I tell all my patients my job as a cardiologist is to improve my patients' health so that they can go on and fulfill their greatest potential. You know, you can't become, you know, a author or take care of your kids or be the best teacher in the world if you're sick. So, you know, I love it when I see my patients really thrive. And again, just because they have heart disease doesn't mean they can't get back to being super healthy. So it's wonderful. Okay, what is this? What course prior to your career do you use daily? What do you mean by that, Ira? I don't understand. What do you mean by what course? So just text me again. Okay, what do you recommend students should do to increase their chances of getting into their preferred medical school? You need to be a well-rounded applicant. So everybody is smart who applies to medical school. You guys, you know, you're going to be going up against everybody with good test scores. You need to be well-rounded. You need to have that extra interesting kind of, what are you going to bring to the medical field that nobody else has? So for me, living in South Africa for 2 years and then doing research in Guatemala and Peru, that definitely made me stand out. You know, no one else had that experience. Nobody else knew what it meant to, you know, work in the townships of Khayelitsha and in Cape Town. So, and again, that made me a better doctor. So you want to, again, be a well-rounded person. I think having a life experience makes you a stronger medical school candidate. That's why don't feel like you have to go high school, college, medical school. It's okay to do something in between, travel, you know, get exposure to the world. That makes you a much better candidate. Let's see, the ways of progress or of learning medicine or specializing in specific aspects of medicine can vary from school to school. Oh gosh. Okay. Yeah, so medical schools are changing a lot. For example, some schools like Yale, there's no grades. You just take your tests. That doesn't work for some people because they need that grade in order to motivate them to study. When you decide on a course of study, again, the most important thing is to know what type of learner you are and what type of environment do you thrive in. So you want to match how you are as a student with the best system of how you learn. I am not an auditory learner. I'm a visual person. I'm a visual learner, which is probably why I'm in cardiology as well. That's why I find cardiology very easy to understand. I loved going to lecture, but just reading a book, or hearing a lecture didn't help. I had to be really actively involved. So medical schools now do a lot of active curriculum or passive curriculum. So when you're thinking about the program you want to join, first understand, and there are a lot of great tests online you can do to figure out what type of learner you are, or your high school guidance counselor can help you with that, or in college, they have all these courses, these little questionnaires you can take. And that will really allow you to say, you know what, this program's better, for me than another program. Okay, let's see. How can, medical school is very competitive, yes. How can undergrad students stand out to administration, hobbies, and extracurriculars? Also, what advice would you give someone who's barely starting undergrad and going down the pre-med track? Again, being well-rounded. When you interview for medical school, they want to see you, they want to see who you are as an individual. Scores are not enough. They want to see, what do you think about the world? Where are your morals? Why do you even want to be a doctor? And if you understand really what motivates you about going into medicine, that comes across, that authenticity comes across very strong. So whether it was an interaction, you know, in the ER with your kid sister or whatever, or, you know, a friend got sick, or your own health, you know, situation where you know, why do you want to go into medical school? Everybody wants to know, because again, it's grueling, it's time intensive. It's a long process. Remember, 4 years of med school, 3 to 4 years of internal medicine, 3 years of fellowship. Oh my gosh, if you want to be a neurosurgeon, your fellowship's 7 years. So it's a really long haul. So you better really want it. So what they're looking for is, you know, obviously that you can understand a massive amount of information, memorize those facts, learn how to take tests, but they're looking for, who's this person going to be as a doctor? Are we going to be proud of this individual when they go out and they've graduated from our medical school? Who is this person that we're putting out there into this world? Is this person going to really take care of the population? And even if you go into research, again, you really want to be that human being that people are really proud of, saying, this person came from our school. So yes, extracurriculars are great. Being a well-rounded human being is really key, you guys. So, and that goes to, again, knowing yourself. But, you know, just having the grades, everyone's going to have the grades. You know that. That's why it's so competitive. You've got to find out what makes you that unique person, okay? Yeah, barely starting undergrad, going down the pre-med track. I would say make sure you're taking classes in literature and philosophy and ethics and culture, because when you get out and you start practicing medicine, you get slapped in the face of the real world situation of how does medicine and health impact with policy, economics, you know, social situations. When I was a chief resident at our county hospital, we had such a homeless, you know, situation that you became a social worker. So when you're pre-med, the whole idea of being pre-med and being an undergrad is to explore your world and really think about, you know, who am I and what do I have to offer, and understanding the world. And so again, even if you're pre-med, you do all your pre-med stuff, think about, you know, what kind of life experience do you need? You know, you don't necessarily have to go right into medical school. Again, you know, I was not pre-med, you guys, and, you know, I've been a cardiologist forever now. So you've got plenty of time. So really explore your world. That will make you such a better doctor. It'll get you into a better medical school. You'll have more resilience in dealing with stress. You'll have more life experiences under your belt, okay? That is the definite advice I would give. Although a lot of my friends, yeah, went straight through, whatever, but, you know, you kind of, I mean, I think that sounds very boring. I cannot tell you how beneficial it was for me to live in another country for 2 years before going to medical school, to travel, to work in, you know, in Central America, and to see extreme poverty and to study some other medical systems. It makes you very grateful to be in America and have access to the opportunities that we have, but also to understand the ramifications of medicine in the world. So imagine those hospitals dealing with COVID, you know, in Central America or in Africa, you know, God forbid that they have outbreaks like they're doing here, because it's so much more challenging. Okay, how did I handle the different standardized tests in, oh gosh, I hated step 1, 2, and 3. I'm a terrible test taker, hated them. I crammed like crazy. And ultimately I just questions. That's about test taking, you guys. If you're not a good test taker, the more mock questions you can do, the better. Just get it over, you know, get it done with. Just, you know, God, just get through it. You're going to be fine. I did not, let's see, when I completed the MCAT, my MCAT scores were average. They weren't that great. Again, I think what stood out for me was my life experience and the fact that I did research with the USDA in Guatemala and Peru, and I lived in Africa, and I did research in Malawi, and I was a very different type of candidate. So it's not all about your test numbers. I am not a good test taker, and yet I was chief resident, I was chief fellow, and now I'm a cardiologist, and it's a pretty competitive field. So don't worry too much about the test, you guys. But I think it's better we get a lot of test anxiety, I think. If you can flip it on its head and think about the tests as, do I really understand the material? Do I really appreciate the material? Think about it that way, instead of kind of focusing on the other side, which is, I got to get this score. Really try to appreciate the chemistry, appreciate the biochemistry. It's really kind of cool. For neuroscience, we did standardized tests, but for all my physiology classes, I actually had to write essays. So I'm much more articulate in explaining things on paper. I can convince myself out of any A, B, C, or D why they're all the wrong reasons and why the test question was terrible, but that doesn't matter, right? So just, I think what would have benefited me better if I had a test schedule and I stuck to it and I just did a little bit of studying. I'm a crammer though, so I don't know if I'm ever going to be like that. I have to redo my internal medicine boards this
Dr.
year.
Adams.
Yeah. Hi.
I just want to thank you so much for answering our questions and being here. Unfortunately, it has reached past the hour mark, so we may need to wrap this up. But then again, I just want to tell you how much I appreciate you coming out here and speaking to all of us.
It's my pleasure, and you guys feel free to just direct message me on Instagram if you guys have any other questions. Great talking to you.
Yeah, we really appreciate you coming here and you're sharing your insight to all the students, and yeah, we all really appreciate it.
Yeah, my pleasure. Good luck to you guys. Keep me posted on how you're doing.
You will.
Bye.
Thank you so much,
Bye,
Dr.
guys.
Adams.
Thank you.
Take care.
Bye.
Take care, everyone. Take care,
Okay,
Doctor.
bye.